Уважаемые коллеги, участники Конгресса и те, кто слушает нас в режиме онлайн, у нас с вами пленарная лекция по плану с 12:40 до 13:20. Меня зовут Боровкова Наталья Юрьевна. Я буду модерировать сегодня пленарную лекцию. Лекция будет с синхронным переводом, и с нами сегодня на связи профессор Камаджа, Франция. Тема его сообщений, его лекции – внедрение рекомендаций по лечению сердечной недостаточности. Почему это важно? Итак, уважаемые коллеги, у нас начало пленарной лекции. Я прошу присоединить к нам лектора.
And how it impacts on the clinical outcomes in this condition. On my cover slide, you can see my declaration of interest. I would like to cover 4 different points. The first one is, where do we stand at the moment? And of course, I'm going to speak of the rate of prescription of recommended medications in heart failure and the dosage used. We will see that the situation is suboptimal. So the second point will be, why is it so? The third point will be the impact of this suboptimal situation on clinical outcomes. And finally, I would like to address some potential points in order to improve the situation. So first of all, where do we stand? This is a survey which was made a few years ago across 34 Dutch hospitals, and they looked at the rate of prescription of recommended medications in heart failure. If you focus on the blue bars, which is heart failure with reduced ejection fraction, you can see that overall the rate of prescription seems to be rather satisfactory. For instance, 60% of the patients were treated by ACE inhibitors, another 30% by ARBs, and around 75% or 80% by beta blockers. However, when you go into the details, the situation is much less optimal. On the top part of my slide is given the rate of prescription for each individual hospital, and you can see that whatever the drug prescribed, loop diuretics, RAS inhibitors, beta blockers, MRAs, there is a huge variation from one center to the other. And if you now focus on the pie charts located on the bottom part of my slide, in the purple area means that people are taking less than 50% of the target recommended dose. You can see that, for instance, for RAS inhibitors, 1 patient in 4 was taking less than 50%, and nearly half of the patients treated by beta blockers were treated by less than 50% of the target recommended dose. And this is very much in line with a survey that we did across the world, which is called Qualify. And the striking fact of this slide, which is on the bottom left part of the slide, it looks at the rate of prescription of beta blockers, which overall was rather satisfactory, 87% in heart failure with reduced ejection fraction, ambulatory patient. But now if you look at the target dose, only 15% of the patients were at target dose, and only half of these of the patients were taking at least 50% of the beta blocker target dose. Let's look at more recent drugs, and of course, I'm alluding to SGLT2 inhibitors. This is a very large survey across the United States, nearly 50,000 patients, nearly 500 hospitals. And if you look at the rate of prescription of SGLT2 inhibitors at discharge after an hospitalization for heart failure, if you look at the orange and pink areas of the curve, which mean that less than 25% of the patients were prescribed these drugs, or less than 10% in pink, you can see that in the majority of the sites, there was a very low rate of prescription of these drugs, which have been shown to improve clinical outcomes in heart failure with reduced ejection fraction or in heart failure with preserved ejection fraction. Does the situation change with time? And unfortunately, we have to say that it does not change much. These are again data coming from the Qualified Global Registry, and we looked in this survey at the percentage of patients taking the target dose of between 50 to 100 or less than 50%. And here is the case of ACE inhibitors and ARBs. And you can see that 18 months after the inclusion in the registry, there is not much change. Of course, there are individual variations, but on average, there is very little change in terms of dosage of the drugs prescribed to these patients who were enrolled with heart failure and reduced ejection fraction. And this is in line with US data. This is the Pinnacle registry, a large registry, and they looked for beta blockers, RAS inhibitors, and MRAs at the change of the dosage after an hospitalization. And you can see that the curves remain flat, and that in particular, those patients who were at very low doses, in red, there is very little change with time. So obviously there is some inertia. More worrisome is these data coming from pooled data from Japan, Sweden, and the United States. For each individual class of heart failure medication, it provides the rate of discontinuation in red. And you can see that at 1 year, a lot of patients stop their medication. And if you look at the bottom part in deep green, a minority of these patients are at target dose. And as we already mentioned, there is very little change with time. So there is a need to invest and to incite to the doctors in order to up-titrate these medications. So why is the situation so? I think that there are 4 different factors which can play a role. One factors are linked to the physician's knowledge, skill, lack of time or resources, or attitudes of on the perception of guidelines. The second factor, very important, is related to patients. Some patients develop side effects, have contraindications to recommended drugs, comorbidities may play a role, polypharmacy and the complexity of the treatment of heart failure may play a role as well. And third factor is guidelines. Some guidelines are too complex and too long, and some doctors are reluctant to go into details of these guidelines. Also, there are delayed disseminations in some areas. And finally, economic or organization factors play a role because the patient journey is inadequate. The cost of medications plays a very important role. And finally, in some areas, there is a lack of healthcare resources. This is an example of what happens. This is the global registry of patients with heart failure with reduced ejection fraction in 44 different countries. And if you look at the bottom part of the slide, those patients who are less likely to be on pharmacotherapy at discharge, by pharmacotherapy, I'm meaning that these patients, when discharged, were under ACE inhibitors, ARBs, or ARNIs, and beta blockers, women, people who are uninsured, and people from low or middle income countries are less likely to receive these recommended medications. Age is another barrier to implementing guidelines medications. Here is shown data from the Czech Heart Failure Registry from the Netherlands once again. If you look at the yellow bars, which are patients above or equal to 80 years of age, you can see that in any instance except loop diuretics, patients over 80 years of age are less likely to receive RAS inhibitors beta blockers, or MRAs. And this is all the more unfortunate as it seems that even in elderly patients, the administration of RAS inhibitors has a favorable impact on clinical outcomes. These are data from the Swedish Heart Failure Registry, and you can see that those patients treated by RAS inhibitors in red have a better outcome, whatever the outcome considered, than those who are not treated by these medications. We performed 2 years ago a survey amongst cardiologists and patients with heart failure across the globe, and we asked cardiologists what were the most important barriers to guideline-recommended pharmacological therapy. And you can see that number one is, of course, related to treatment side effects or intolerance, which is a hurdle to up-titrating these medications. The complexity of the treatment of heart failure is also a major issue, as well as low blood pressure, cost reimbursement issues, impaired renal function, older age, or low heart rate. And this is very much in line with this different survey where cardiologists were asked what were their main concerns about using guidelines-recommended heart failure medications. And in this survey, you can see that once again, hypotension, creatinine increase, risk of hyperkalemia or bradycardia are amongst the most troublesome factors for prescribers of heart failure medications. Other factors, which I already mentioned, are of course the reimbursement issue, the price of treatment, the clinical inertia, and the fact that the management of heart failure involves polypharmacy. You can see that in the deep red, these factors play a very important role in the concerns of cardiologists. The other issue that needs to be addressed is that some doctors do not have a clear view on what should be the priorities. And here again, we come back to Revolution, the registry that we did, the inquest that we did among cardiologists. And surprisingly, although prolonging life appears first, followed by reducing the number of hospitalizations and alleviate heart failure symptoms, if you look at the bottom part, most of the functional issues appear to be the majority of the concern of doctors and not prolonging life or reducing hospitalization. So, of course, we need to improve the skills of prescribers. What is the impact on clinical outcomes of this situation? And I wrote need for speed. This is data coming from the European Biostat registry, and in this survey, people looked at the impact of prescribing at target dose or below target dose ACE inhibitors, ARBs, or beta blockers on survival. And you can see that those patients who are treated by low doses of any of these two classes of heart failure medications have a higher rate of mortality than those patients treated at full dose. We observed exactly the same pattern in the Qualify registry, where we built a score based not only on the rate of prescription, but also on the dosage reached in these patients. And the higher the score, the better the outcome. And you can see that this holds true both for heart failure mortality or for the composite made of heart failure hospitalizations or cardiovascular deaths. And indeed, there are some data suggesting from that the modern therapy, by this I mean use of SGLT2 inhibitors combined with MRAs together with beta blockers, can substantially increase life expectancy in patients. And in this pool of different heart failure trial with SGLT2 inhibitors, it was striking to observe that the prolongation of life expectancy in these patients. So we should really try to modern therapies whenever possible. Also plays a role. This is also coming from clinical trials using SGLT2 inhibitors. And you can see that, for instance, for heart failure hospitalization or cardiovascular death, the best sequence is the sequence called 2, with first introduction of SGLT2 inhibitor, then an ARNI, third MRAs, and 4 beta blockers. With this combination and this sequence is associated with the lowest rate of events for these patients. Another incentive of going fast in order to try to up-titrate medications come from the strong heart failure trial, where patients were randomized either to a classical and conventional therapy or to an intensive therapy, and they were progressively up-titrated with a very careful follow-up. And they looked at the rate of prescription at 180 days. And not surprisingly, this is shown in red, the rate of prescription of drugs in the intensive care arm was higher than in the conventional arm, without any clear signal of harm in terms of side effects, provided that there was a careful monitoring of both the clinical status and of biological status of these patients. And indeed, in these patients hospitalized for acute heart failure, whatever ejection fraction, I should say, there was an improvement in clinical outcomes with a risk reduction of approximately 10% in this or other clinical outcomes. Another and final point which I would like to make has been recently published. It deals with patients who have improved ejection fraction. And I think the striking fact of this recent publication is that in those patients who had an improvement in ejection fraction, which was defined by an EF of more than 40%, and a more than 10-point increase in ejection fraction, the rate of prescription of medications, be it RAS inhibitors, beta blockers, MRAs, ARNI in green, was much higher than when the patients were included in the survey. We suggest that the reverse remodeling play is really linked to prescribing recommended medications in heart failure. Finally, if the situation is suboptimal, can we improve the situation? I think that we should try to draft simple and concise recommendations in order to provide pocket versions of these guidelines so that doctors have a very fast look at what should be done or not be done. The role of multidisciplinary programs is key also, in order to include not only cardiologists, but GPs, heart failure nurses, dietitians. Patient education is also very important in order to provide to patients a clear view of the target and the aim of the treatment, and maybe in the future, artificial intelligence will help us in order to have a better implementation of heart failure guidelines. This is to highlight how important guidelines are for the doctors. And you can see that in the Revolution Heart Failure survey that we did, for cardiologists, 40% or so said that guidelines and position papers were key documents in order to allow them to have a proper management of heart failure patients. Now, if we ask patients now, what is the best source of information about your disease? Not surprisingly, cardiologists come first, followed by general practitioners and heart failure nurses. So we must underline the role of healthcare professionals in providing a good and concise information about their condition to our heart failure patients. The problem is that many of these patients hardly see a cardiologist once or twice a year. On the left part is again the survey amongst patients. They were asked, how many times do you see your cardiologist in the last 12 months? And you can see that nearly 50% of these patients saw their cardiologist none once or twice a year. And now, what about heart failure nurses? On the right-hand pie chart, here again, 46 patients of the patients did not see any heart failure nurse during the 1 year of follow-up, which means that we really try to organize the patient journey using all healthcare professional resources as possible. And I would like to highlight that the ESC guidelines, as well as the American guidelines, provide a class 1 level A recommendation for using multidisciplinary heart failure management programs. Finally, it may be that artificial intelligence will help us soon in order to try to identify patients who are at very high risk after an hospitalization. This is a recent survey paper that we did using artificial intelligence and structured data. And in this survey, we could identify 3 groups of patients at high, intermediate, or low risk of 90-day mortality during the vulnerable period after the discharge, so that this could help in order to target, in particular, the patients who are at the highest risk of mortality after a hospitalization for heart failure. And finally, I would like to conclude by this very interesting and intriguing artificial intelligence survey, where they used vocal biomarkers. So they asked patients after a heart failure hospitalization to speak, and this was analyzed by artificial intelligence. And strikingly, they were able in this survey to identify once again patients who were at high, moderate, or low risk of being re-hospitalized after a heart failure hospitalization. So probably with the progress of artificial intelligence, we will soon have new biomarkers and hopefully be able to identify those patients who are at the highest risk of being re-hospitalized or of dying after a heart failure hospitalization. With this, I would like to conclude my lecture and to thank you for your attention.
Уважаемые коллеги, мы прослушали очень интересное сообщение профессора Михаила Камаджи. И хотелось бы подчеркнуть, что вот такое междисциплинарное взаимодействие и говорят ученые на одном языке. Мы с вами сейчас прекрасно поняли, что он хотел сказать в своей лекции, а именно подчеркивал проблему лечения пациентов наших с сердечной недостаточностью, как ее лучше решить. И, конечно же, здесь четко прозвучали наши общие с вами проблемы, да, и российской, и зарубежной медицины, в том, что, конечно же, очень много путей для того, чтобы мы могли лучше не только внедрять клинические рекомендации для лечения наших пациентов, но и, конечно же, лучше лечить их, лучше получать ответ на лечение у наших пациентов. У нас одна лекция, и хотелось бы все-таки еще раз акцентировать вот на оставшееся немножечко время, у нас немножко осталось, да? Хотелось бы подчеркнуть, что очень важно то, что сейчас делается акцент в клинических рекомендациях на приближение к практической жизни, к практической деятельности. Профессор Камаджа сказал о том, что, конечно, пытается эти рекомендации упростить, с одной стороны, да, для того, чтобы врач мог лучше пользоваться этими клиническими рекомендациями. С другой стороны, в рекомендациях, опять же, конечно же, соблюдаются все необходимые точки приложения, и очень хорошо подчеркнул профессор Камаджа о том, что мы с вами не должны быть инертны, мы должны обязательно действовать согласно клиническим рекомендациям. Мы должны с вами понимать, насколько пациент привержен к тому, что мы назначаем, и проводить с пациентом работу. По возможности, вот также в этой лекции упоминалось то, что нужно работать мультидисциплинарно, привлекать медицинский персонал к тому, чтобы работать с пациентами и получать лучший отклик на лечение, потому что пациент будет лучше понимать важность, опять же, проводимой терапии. Это явно снизит и риск госпитализации, и риск смертности. Вот очень важно то, что в этой лекции профессор Камаджа, он очень хорошо подчеркнул то, что мы в своей практике часто боимся усиливать терапию, действуем осторожно и стараемся использовать, может быть, не совсем те дозы, которые нужны были, потому что боимся побочных эффектов. Поэтому, конечно же, он показал очень хорошо вот в своей презентации, что назначение оправданных, достаточно высоких доз ведет, конечно, к улучшению результата. Здесь же у нас с вами возникает много проблем. Мы говорили про дозы о возрасте, да, и учитывать коморбидность пациентов. Но с другой стороны, конечно же, в данном случае все-таки нужно делать упор на исполнение клинических рекомендаций и учитывать то, что в этих рекомендациях нам прописано. Есть проблема экономики. В данном случае здесь профессор хорошо показал результаты исследований, где показано, что с одной стороны есть и низкая грамотность, и недоверие пациентов, и экономически трудные вопросы, которые со стороны нашей сферы здравоохранения и лично даже состояние кошелька пациента трудно учитывать, но экономически обоснованно является правильное использование клинических рекомендаций, и это может помочь нам, опять же, прийти к снижению риска смертности, госпитализации и продолжения жизни наших пациентов. Очень важно то, что вот профессор подчеркнул междисциплинарность, информированность и наше с вами внимание к четкому исполнению рекомендаций, которые сейчас адаптируются и более упрощены для того, чтобы мы с вами принимали это в своей практической жизни. И еще, уважаемые коллеги, в нашу жизнь врывается искусственный интеллект. Вот на настоящем конгрессе, смотрю, это вот как бы эволюционно идет, да, по прошлым годам и нашим конгрессам прошлых лет. Все больше и больше симпозиумов и докладов посвящено использованию искусственного интеллекта. Мы сейчас говорим про использование искусственного интеллекта в кардиологии. Очень хороший был доклад также на открытии про искусственный интеллект в программе, вы это увидите. И мне очень понравилось, как профессор Камаджа показал преимущество того, что мы с вами вступаем в эру, когда искусственный интеллект может нам помочь в ведении наблюдении и получении хороших результатов больных сердечной недостаточностью. Уважаемые коллеги, у нас с вами время, по сути дела, исчерпано уже в плане того, что мы с вами обсудили все эти темы, и я думаю, что эта лекция вам была очень полезна. Мы четко расставили приоритеты в том, чтобы вы понимали, что лучше внедрять и как лучше внедрять рекомендации для лечения больных сердечной недостаточностью. Поэтому мы, конечно, очень благодарим наш Конгресс, Российское кардиологическое общество, что они позволили нам услышать такую замечательную лекцию. Уважаемые коллеги, всего самого доброго. Спасибо.